Θα κάνουμε μια αλλαγή στο πρόγραμμά μας, γιατί ο κύριος Μαμουνας, ο Λευτέρης μας, θα πρέπει να φύγει, να ταξιδέψει, οπότε θα του δώσουμε μια προτεραιότητα. Πιστεύω ότι τον κύριο Μαμουνά τον γνωρίζετε όλοι. Καθηγητής χειρουργικής στην Αμερική. Τιμή μας μεγάλη που είναι εδώ. Θα μας πει τα αποτελέσματα μιας πρόσφατης μελέτης. Μπορείτε να ξεκινήσετε.
Ναι, ευχαριστώ. Μια στιγμή. Το mouse εδώ δεν πάει έτσι. Ωραία. Ευχαριστώ πάρα πολύ για την πρόσκληση. Μεγάλη τιμή μου να βρίσκομαι μαζί σας και ευχαριστώ επίσης που με βάλατε λίγο νωρίτερα ώστε να φτάσω στο αεροδρόμιο εγκαίρως. Θα μου επιτρέψετε να την κάνω την ομιλία στα αγγλικά για να τελειώσουμε σε ένα δυνατό χρονικό διάστημα. Σήμερα θέλω να μιλήσω για προεχειρητική χημειοθεραπεία σαν μια μέθοδο με την οποία μπορούμε να εξειδικεύσουμε την τοπική θεραπεία του καρκίνου του μαστού. So, neoadjuvant chemotherapy for tailoring locoregional therapy in patients with early-stage breast cancer. So, as we know, neoadjuvant or preoperative chemotherapy, the evolution of the clinical rationale, we started using preoperative chemotherapy in patients who had inoperable breast cancer to convert them to surgical candidates. And then randomized trials in patients with locally advanced and large operable breast cancer showed that preoperative versus postoperative chemotherapy had very similar outcomes. And as a result, neoadjuvant chemotherapy became an alternative to adjuvant chemotherapy and had some potential clinical advantages, but as I underline, in appropriate candidates. And we'll talk a little bit some of those advantages in the locoregional management. We also know that the achievement of what we call pathologic complete response, which is essentially the elimination of invasive disease in the breast and also in the axilla if it was present before, is an important outcome because it signifies the very good outcomes of patients if they achieve pathologic complete response. In fact, years ago, the regulatory authorities in the US in 2013 accepted PCR, or pathologic complete response, as an endpoint by which they could approve new drugs. And at the time, pertuzumab for HER2-positive breast cancer was approved based on increase in pathologic complete response compared to the standard of care. Now, pathologic complete response varies by subtype, for sure, as we see here. For patients, this is the meta-analysis by Pat Cortazar. For patients with ER-positive breast cancer, hormone receptor-positive breast cancer on the left, we see that the pathological complete response is fairly low, particularly for grade 1 and 2 tumors, but for grade 3 tumors it reaches about 16%. And this is with chemotherapy where we had anthracyclines and taxanes, doesn't include some of the recent newer agents that we include. If you look on the other side, in triple-negative patients, about a third of the patients had pathologic complete response. And in the middle, we see what happened to the HER2-positive patients. And with HER2-positive patients, some of the studies included in the meta-analysis had chemotherapy alone, and some other studies started using neoadjuvant trastuzumab or Herceptin. So you can see that in the hormone receptor-positive, HER2-positive patients, 18% had pathologic complete response when there was no Herceptin, but where Herceptin went to 30%. And then for the hormone receptor-negative, HER2-positive, about a third had a pathologic complete response if there was no Herceptin, but when Herceptin went to 50%. So significant progress, of course, in the treatment of HER2-positive breast cancer, and these numbers, as I will show you, continue to increase. Now, when you look at the association between having a pathologic complete response and outcome, it's very prominent for patients who had triple-negative breast cancer, as we see here, whereas you can see patients that achieved it do very well, and those that do not do well at all. And then for the hormone receptor negative HER2-positive, you see the difference as well. And even in the high-risk hormone receptor-positive HER2-negative patients, grade 3, you see the difference. But you don't see much of a difference in outcome, for example, in hormone receptor-positive grade 1 and 2, because those patients do well either way, because they will receive endocrine therapy afterwards. And you see the remaining. So clearly, pathological complete response is an important endpoint. Now, a lot of debate after this meta-analysis was that if you increase pathologic complete response in a study, do you see the equivalent increase in event-free survival or disease-free survival? And the answer was it was not the case, mainly because there was a variety of tumors included in most of the studies and the differences were small. But I showed this slide to highlight that historically, as we see increase in pathologic complete response, we also see improvements in disease-free survival and overall survival. We see, for example, with CMF, it was about 7 to 8% only, and then anthracyclines, it doubled to 15%, and there was significant improvement in disease-free overall survival. And then we go to anthracyclines, taxanes, another doubling to 25 to 30%. And then the HER2-positive patients with trastuzumab or dual anti-HER therapies, we see pathologic complete response go in the 50s and 60s, and we see also improvements in disease-free overall survival. For triple-negative breast cancer, for the 30% with anthracyclines and taxanes, 35%, with addition of carboplatin, we see 50 to 55%, and then with immunotherapy, the checkpoint inhibitor, now we're about 65% and above. And those also significantly improve disease-free survival. The carboplatin was still somewhat debatable, but a recent study, the Brightness study, actually showed that there is an event-free survival with carboplatin. And when we see meta-analysis, I'm sure that will be confirmed as well. So, knowing all that, how can we maximize the clinical impact of neoadjuvant chemotherapy in the era of precision medicine? Well, first of all, we can identify patients that have high likelihood of pathologic complete response. They seem to be the ones who benefit the most. And we can do that with the baseline biomarkers, or also by looking at changes in the biomarkers with neoadjuvant chemotherapy, such as, for example, Ki-67 with endocrine therapy. And we use the PCR as a surrogate endpoint to approve new drugs. Of course, now the FDA also mandates that you also have an event-free survival benefit, not only PCR benefit. And lastly, use the tumor response to neoadjuvant chemotherapy as a guide to individualize decisions of local regional therapy, which we're going to be talking about today, and also systemic therapy, which I'm not going to touch, but as you know, the approval of several different drugs, if you use a set of drugs in the neoadjuvant setting and you don't have a PCR, you always can add those drugs later on, and we have several studies that have shown that that strategy works. For example, in HER2-positive patients, the introduction of TDM1 in the Catherine trial showed that it was significantly better than continue the traditional antibodies, the Herceptin or Herceptin Perjeta. So we'll talk about local regional therapy. So in terms of local regional therapy, we started with the breast. Of course, we converted the inoperable patients to operable candidates, and of course, we converted mastectomy patients to candidates for breast conservation by shrinking the tumor. And as surgeons, we know also that even if a patient is a candidate for breast conserving surgery, but has a large tumor in a not very favorable location, shrinking it down and making it smaller leads to a more cosmetic surgery and higher probability of having negative margins. Now, one of the challenges is how do tumors shrink in response to neoadjuvant chemotherapy? And of course, this is a well-traveled slide. I think Bernie Fischer did some version of this years and years ago. And some tumors, the fact is that they shrink concentrically. They grow fast, and then they shrink concentrically, where if you did a smaller lumpectomy, then I think we'll be fine with the margins. But some other tumors tend to shrink, but then islands of tumor remain in the area of the tumor bed. So if you did a smaller lumpectomy, you probably would not be able to get clear margins. So the challenge is to find this is where is your patient? And biology is what dictates mostly this. For example, the fast-growing tumors, the triple-negative, the HER2-positive grade 3 tumors, tend to shrink concentrically. And of course, if you have a pathologic complete response where there is no tumor, then really it doesn't matter because there's nothing to worry about. But the ER-positive patients, lobular carcinoma, low-grade tumors, tend to shrink this way. And in fact, sometimes the scaffolding of the tumor remains, so you won't be able to do a lesser procedure. So I'm less enthusiastic about those tumors getting neoadjuvant chemotherapy, and the studies also show they have a low rate of pathologic complete response. But in particular, the HER2-positive and triple-negative tumors are the ones who benefit the most from neoadjuvant chemotherapy. The other challenge, of course, is to know exactly where the tumor was if it goes away. For example, this is a very ill-defined tumor, which is actually triple-negative, and you can even not see where the tumor is. It's around there. After neoadjuvant chemotherapy, you see how it all went away. And if you didn't have the radiopaque clip that we put in at the time of biopsy, you will know for sure exactly where to go, and you'll be doing a bigger surgery where you can do a much smaller surgery. This patient did have a pathological complete response. So, of course, preoperative titanium clip placement is mandatory. We do it all the time. And localization and removal is the standard. We did that before with wires. Nowadays, we use a lot of the more wireless methods, which are very applicable for neoadjuvant chemotherapy, not only in the breast, but also in the axilla, as we'll be talking about in a minute. So you see the radioactive seeds, the Savage Scout, the radiofrequency reflectors, magnetic seeds are things that we use routinely now to find where the tumors used to live and do a smaller lumpectomy. It's very important to be targeted about surgery because we know from the meta-analysis and many studies that patients that undergo neoadjuvant chemotherapy in the downstage from mastectomy to lumpectomy tend to have a little bit more local recurrence. And so in the meta-analysis, the overview analysis, the recent overview analysis, we see that about a 3% increase in local recurrence with neoadjuvant versus adjuvant chemotherapy, and this is in studies where surgery took place. This difference is much bigger if surgery did not take place. Some of the French studies, for example, if they have clinical complete response, they radiated after. They did not do surgery, and those patients had a lot more local recurrence. So surgery has to take place, and surgery has to be strategic and very targeted to make sure we get the area of the tumor out. So the second part, though, is once we establish in the breast that this works, then what about the axilla? And of course, the axilla became a second thought because we always did axillary dissections for these patients. So whether you sterilize the nodes or not, then you're still going to do an axillary dissection. But with a sentinel lymph node biopsy, now we have an opportunity to downstage the tumor and potentially decrease the extent of surgery. Also, the idea that maybe we can reduce the extent of local regional therapy, we'll talk about that later on, came by downstaging the primary tumors and axillary nodes. And of course, there's always a potential of eliminating a modality altogether. In other words, don't do surgery at all in the breast, or don't do surgery in the axilla, or don't do radiotherapy at all. So we'll talk a little bit about some of the newer studies. Now, we know that the effect of the neoadjuvant chemotherapy in axillary metastasis is probably as good, if not even better, than in the breast. So in the earlier randomized trials, the B18 and B27 and some of the other trials, we saw about a 30 to 40% conversion of positive lymph nodes to negative lymph nodes. And so, of course, these numbers are much higher now that we know that we can get up to 50 to 75% axillary downstaging. So this is the potential of decreasing axillary surgery for sure, and I'll show you some of the data that we can do that. Now, this concept is applicable to patients with operable breast cancer. We're not talking about locally advanced T4. We're not talking about clinical N2 necessarily or inflammatory breast cancer because we don't know the accuracy of sentinel lymph node biopsy in this setting. And some of the data suggests it's not very accurate. But we're talking about clinical T1, 2 T3, clinical N0, N1 operable breast cancer. In addition, a very useful tool is the axillary ultrasound. That is a very simple, minimally invasive technique, can give us information about the status of the lymph nodes, even cortical thickening can be identified. We can then biopsy the suspicious nodes and leave a clip there that we can then use later on to identify the node that was biopsied before and found to be positive for removal. So how do we deal with patients that present with clinically negative axilla before neoadjuvant chemotherapy? For years there was debate. Should we do the sentinel biopsy before or after? And after many years, the after school prevailed. So we like to do it after because we like to capitalize on the downstaging effect. Because even those patients that are clinically non-negative, they may subclinically harbor cells in the lymph nodes. And in fact, in the B18 study, about 48% of the patients where the surgeon didn't feel any lymph nodes by his finger had disease when they went to surgery first. This approach, again, capitalizes on the downstaging effect. And at the end of the day, there is actually no difference in the identification rate of the sentinel node or the false negative rate in a meta-analysis. We see 96% identification rate after neoadjuvant chemotherapy, and the false negative rate 6%. So clearly that works pretty well. But what about patients that present with documented positive nodes? They have a palpable node or ultrasound positive node, you put a needle, it's positive. Is it safe to do sentinel lymph node biopsy in these patients without a completion axillary dissection? And these are 4 prospective trials that address this question. In these cases, they all had positive nodes before documented, and then all had sentinel lymph node biopsy followed by an axillary dissection to check on the false negative rate. And we were aiming for a false negative rate of about 10%. We thought that would be okay. But in fact, as you can see, we got a little higher, 12 to 14%. And only in one study, the Canadian trial, was 8.4%. But this study, they used also immunohistochemistry to find disease in the nodes by immunohistochemistry. So they did a different technique. So this wasn't as good. So then we said, well, maybe there could be other things we can do, dual mapping, maybe take a little bit more, few more nodes. And in fact, as you can see here, if the number of sentinel lymph nodes removed increased, the false negative rate went down. And you can see with one sentinel node in the Z1071 was 31%, it went down to 9% with 3 or more. And here from 24% to 7.3, even the Canadian, 18% if you take one lymph node, and if there were 2 or more, 4.9. And the French study as well, the same thing. The next thing, though, in one of the studies, the Z1071, Judy Bowie published this paper, when they looked back on the patients that had a clip in the node, that was when we started doing that. When they found the clip in the node, the false negative rate in the sentinel node, the false negative rate was only 6.8, but if the clip was in the axillary dissection specimen, it was 19%. So clearly that gives us an idea that maybe the clip is important to remove. And then there was a study from MD Anderson that actually they took about 190 patients and they did sentinel lymph node biopsy. They also removed the node that was clipped before. And then they looked at the false negative rate according to what nodes they will count. So if they counted the sentinel nodes only taken out, the false negative rate was 10%. If they counted the clipped node only, the false negative rate was about 4.2%. And if they said, okay, if we count both the sentinel node and the clipped node, it dropped to 1.4%. So much more accurate removal by the targeted dissection. And the reason for that was that about 23% of the patients in this study, the clipped node was not a sentinel node. Did not identify as a sentinel node because it was probably scarred down from the tumor and the response, and the pathway bypassed the node. Since then, we have now even prospective studies that validated the low false negative rate. This is the RISAS trial, the Dutch group. The Dutch group actually puts a radioiodine seed in the node before neoadjuvant chemotherapy and then takes the radioactive node out. This is called the MARI procedure. And with that, they had a false negative rate of about 7%. But the RISAS trial included taking out the MARI node, but also taking out the sentinel nodes, do a dual approach. And with that, the false negative rate dropped to 3.7%. So a prospective trial that validates. Now, there is a lot of debate whether you should do that or not to do that. Some people say it's increasing the cost, increasing the inconvenience and this. But the fact is that if we want to do precision medicine and have a targeted approach, this is the best. Because this doesn't have only implications in terms of local recurrence in the axilla, also has implications in selecting appropriate systemic therapy after. And you don't want to miss a node that was positive and call the axilla negative. So my bias is to do it, and that's how we practice. In some institutions, though, they don't. And the reason that they don't want to do that is they say, well, the local recurrence rate in the axilla is very, very low. These are several studies, clinical N0, clinical N1, and 2, that convert to negative nodes, and you can see that the axillary recurrence is very low. So, but that's the two different issues here. And of course, if, let's say, you do all that and the sentinel node is still positive, then axillary dissection is the standard, because several studies have shown that the non-sentinel lymph node positivity in this setting is very high, 60 to 70%. So if the nodes are still positive, axillary dissection remains the standard. Until perhaps you see the results from this study, the Alliance 11202 trial, that actually takes these patients, clinically not positive before, biopsy proven, and now still the sentinel node is positive, and randomize them to axillary dissection or not, assuming that all these patients will get local regional radiotherapy, which actually they did because they were positive, they're still positive. Now the question is, does this extend even though to micrometastasis or isolated tumor cells in the sentinel node? And the answer is, with micrometastasis, you still see in several studies that there is a substantial proportion of patients that have positive non-sentinel nodes. But with the isolated tumor cells, the numbers are so low in some of these studies that we can't tell for sure. It looks like about a third. So very briefly, I'm going to show you a study from San Antonio this year, where in a group of investigators taking all the patients that they can find in a large consortium of hospitals, about 700 patients or so that had T1 to 4 and 0 and 3, they had neoadjuvant chemotherapy, they excluded some, and after a median follow-up of 3.2 years, some had an axillary dissection, some did not. So they calculated if the sentinel node was positive for isolated tumor cells, what would be the chance to find in additional cells in the non-sentinel nodes? And it was 5% macromets, 7% micromets, and 18% additional isolated tumor cells. So really, if you want to count just positive nodes, it was only 12%. And then they looked at it according to if they did an axillary dissection or not. It wasn't by randomization, it's just what happened, and then they see no difference. So I think it's safe to say for isolated tumor cells, we probably don't need to go back and do an axillary dissection. That's the conclusion of these authors. So now we're just to change a little bit the subject. Can we use this response to neoadjuvant chemotherapy in the nodes to reduce the extent of radiotherapy? That was the hypothesis that we made years ago based on the fact that we know patients with positive nodes benefit from radiation with ample benefit if they have surgery first. But after neoadjuvant chemotherapy, they convert the nodes. We weren't sure if these patients would behave like node positive and benefit from radiation or like node negative, which case they wouldn't benefit. And of course, we have published some data earlier on to show that if the patients convert the nodes from positive to negative from the B18 and B27 study, the rates of locoregional recurrence were much lower. So we're hopeful that maybe we can downstage these patients and not forego radiotherapy. So this is the NRG Oncology NSABP B51 RTUG 1304 that we presented just in San Antonio last week. So this was patients with axillary lymph node involvement by core biopsy or refined needle aspiration, documented, neoadjuvant chemotherapy plus anti-HER therapy if they were HER2 positive, and then the nodes were negative by surgery. And that surgery could be axillary lymph node dissection or sentinel lymph node biopsy followed by an axillary dissection or just sentinel lymph node biopsy alone. And the stratification you see here by type of surgery, hormone receptor status, HER2 status, adjuvant chemotherapy, and pathologic response in the breast as well or not. And then the randomization was to the no regional radiation group or no RNI or to the RNI group. In other words, regional radiation. However, of course, if the patient had breast conserving surgery, they all got radiation to the breast, both in this group as well as in this group. But if they had mastectomy, in this group they had no chest wall radiation, but in the group, the RNI group also included the chest wall. So you can see how we randomized. The primary objective was to determine whether the addition of regional radiotherapy improves invasive breast cancer recurrence-free interval. That includes invasive local recurrence, regional recurrence, distant recurrence, and death from breast cancer. These are the endpoints. And then secondary objectives that we report in San Antonio was local regional recurrence, isolated local regional recurrence, distant recurrence-free interval, disease-free survival, overall survival, and toxicity. So as you can see, the eligibility to anti-3-in-1, biopsy proven, at least 8 weeks of neoadjuvant chemotherapy. The axillary nodes, if it was by sentinel lymph node biopsy, we have at least 2 nodes removed, and our axillary dissection or both, mastectomy or lumpectomy, and known ER, PR, and HER2 status. The study had an 80% power to detect about a 35% difference or a 4.6% absolute difference between the two groups. However, to do that, we had to encounter 172 events in the 1,600 patients that we accrued in the study. But also, we were supposed to analyze the study 10 years after initiation of the first patient. The first patient went on study in 2013, and 10 years happened in 2023. So we reported in San Antonio the time-driven analysis, although, as you can see, our event rate was a little bit lower. We had 109 events only. So the power is a little bit less than we originally planned for at this point. And of course, it was an intent to treat analysis. So from September 2013 to 2020, 1,600 patients were randomized. We excluded some because of no follow-up, not at risk of the primary endpoint. And then at the end of the day, we have 1,556 patients, you can see, in the two groups. The median follow-up was about 5 years, 59.5 months. I won't belabor this too much. The patient characteristics were well balanced between the two groups, but about the median age was 52 for both groups, and 40% of the patients were under or equal to 50, right? So younger patients were included, T1 about 20%, T3 20%, and about 60% T2 tumors. And then the subtypes you see, every subtype has about a 20% representation, 25 to 30%. Triple negative, 20%, ER/PR positive, HER2 negative, about 20-some%. ER negative, HER2 positive, 25%, and ER positive, HER2 positive, triple positive, 30%. breast surgery, lumpectomy 58%, sentinel lymph node biopsy alone about 55%, and PCR in the breast also 78%. Now, it's normal to have more PCRs because people were selected for that. And adjuvant chemotherapy, very uncommon. So these are the results. So this is the invasive breast cancer recurrence-free interval, the primary endpoint. 109 events, 59 in the no RNI group, 50 in the RNI group. The hazard ratio 0.88, no significant p-value. And the absolute estimates 91.8% at 5 years for the no RNI, 92.7% for the RNI, so 0.9%, less than 1% absolute difference between the two groups. Now, this summarized all the secondary endpoints in one slide. Isolated local recurrence that we defined as local recurrence, locoregional recurrence without distant recurrence within 2 months. There were 11 events in the no RNI and 4 in the RNI, hazard ratio 0.37, so there's a little bit of benefit in local recurrence, not significant, but again a 0.9% difference, 98.4 to 99.3. We expect a little bit difference in local recurrence, of course, because of no radiation. Distant recurrence-free interval, though, absolutely no difference. The hazard ratio is 1. The absolute 5-year estimate is 93.4 for both groups. Disease-free survival, hazard ratio of 1.06, no difference. 83 versus 85 events, 88.5 versus 88.3, almost 0.2 better for the no RNI. Overall survival, no difference, of course, as you can see here as well. Now, we looked at subsets of patients based on the stratification factors. No difference in the effect of radiotherapy according to surgery, ERPR status, HER2 status, PCR breast, or adjuvant chemotherapy. You see that the hazard ratios are around 1, some of them on the side of a little bit of a benefit, couple very little on the other side. But no difference, I remind you this because of the next slide. ERPR, no difference, a little bit more for ER positive than for ER negative, benefit from radiation. And HER2 positive, a little bit more for HER2 positive versus negative, right? But all of them overlap 1, of course. Now, we then did a subset exploratory analysis according to age, race, tumor subtype, and axillary surgery. And of course, there was no difference according to the age of the patient, race, and axillary surgery. But tumor subtype was a little bit weird. So here we see that for triple-negative patients, the hazard ratio is 2.3, meaning that patients in the no radiation group did better than the radiation group. That we cannot explain that off. And almost touched to 1. So there was a significant interaction. For the ERPR positive, HER2 negative, there was more benefit from radiotherapy with about a 0.41 hazard ratio. And then the HER2 positives kind of fell in between. You see, not much of a difference. So, you know, of course, I caution you here because there are very few patients in every group. So a couple events may have changed this, so we need to follow clearly more. Some people look at this data and say, okay, for the triple negatives, we're okay, maybe not do radiation. For the HER2 positives, okay. But for ER positive, HER2 negative, you know, we still don't know. And I think for those patients, we have to be cautious and maybe discuss it further. So our conclusion was that based on these findings, patients that have biopsy-proven lymph nodes or convert their nodes to negative, it appears that they did not improve their primary endpoint as well as secondary endpoints with regional nodal radiation. And these findings suggest that downstaging the involved axillary nodes and make them negative, we can optimize the adjuvant radiotherapy without adversely affecting oncologic outcomes. But of course, continuing follow-up of these patients is very important. So to finish in a couple minutes, and sorry that I went a little bit over already, the other two questions: can we omit surgery in patients with a complete pathologic response? You know, a lot of investigators have found that if you, by imaging, see that the patient has a complete radiologic response, and then you go and biopsy the tumor bed with core biopsy, then you may be able to predict whether they have pathologic response better or not. But some of the retrospective studies show very variable false negative rates, as you see here, and only after customizing this to less than 2 centimeters in one study and 6 biopsy cores, maybe the false negative rate dropped. But more importantly, we had prospective studies, including our own here, that showed that the false negative rate in this situation of the biopsy, the core biopsy, wasn't very good. So based on that, we did not feel that we can move forward with a phase 3 study to formally omit surgery from the breast. However, MD Anderson actually did a small study, single arm, where the highly selected patients they had response. Out of 58 patients, 31 patients had a biopsy on the tumor bed, and there was no disease. And they follow these patients prospectively without surgery. And as you can see, the 3-year data look very good. So far, no recurrences. 100% of the patients are free of ipsilateral breast tumor recurrence. So we'll see, but yet I don't think we're ready to launch a big phase 3 trial. And the last, what I mentioned to you now, we started to say, well, patients with HER2-positive disease do so well with neoadjuvant therapy or also with adjuvant therapy in the early stage. Can we now omit breast radiotherapy for these patients to the same degree that we're trying to do for the ER-positive, HER2-negatives? So this is one of the NRG trials that we just started in HER2-positive patients that come into the study if they have a 2-centimeter tumor or less and they have a front surgery, the nodes are negative, or have 3 centimeters or less, have preoperative chemotherapy with clinically negative nodes, and now have a pathologic complete response. So these patients are randomized to standard radiotherapy in the breast or not. Assuming that because we do so well with systemic therapy, maybe these patients will have very low risk of in-breast recurrence. So we'll see where that takes us. It's going to be a little while, 1,300 patients, but clearly that's where we are. So to summarize, I think neoadjuvant chemotherapy clearly has allowed us de-escalating surgical therapy in the breast and the axilla. The de-escalation has occurred to a greater degree for triple-negative breast cancer, HER2-positive breast cancer, but also in selected ER-positive, HER2-negative patients. And of course, further de-escalation of regional radiotherapy based on response to neoadjuvant chemotherapy appears at this point to be oncologically safe. Thank you very much for the honor to be here today. I'll be happy to answer any questions.
Ευχαριστούμε πάρα πολύ. Ειλικρινά ευχαριστούμε πολύ. Ερωτήσεις από το ακροατήριο.
Yes.
Κυρία Καραγιοργοπούλου.
Hello, it's a great privilege to have you with us, and thank you very much. So I'm a medical oncologist. It's really interesting to see how your team is trying to downstage the, first of all, with neoadjuvant chemotherapy, the axilla, and then do less surgery and perhaps less radiation. But I am wondering, during this process and until you have really definite results, would you ask your medical oncologist to do more adjuvant treatment after this less local therapies? Do you feel safe to have a patient that doesn't just had sentinel lymph node biopsy and no radiation, and then perhaps this patient might have isolated tumor cells in the axilla, and in that point, we would do more adjuvant treatment. So you would ask your medical oncologist in your practice to do more, or you would feel safe to do less also in the adjuvant systemic treatment?
That's a great question. And literally the short answer is we would not, because our medical oncologists actually who got us here, they did their job already. They gave neoadjuvant chemotherapy and they sterilized the lymph nodes. And they put the patient in a very good prognostic category. So we don't do anything different. Whether we give radiotherapy to the axilla or not, if the nodes are negative, and the patient has a pathologic complete response in the breast as well, for example, HER2-positive patients will continue with the antibodies, we don't switch to TDM1. Triple-negative patients don't get adjuvant therapy, except pembrolizumab if they were in the keynote regimen. So we don't ask you to do anymore because I think you already did. I think that's the answer. Now, isolated tumor cells, we don't count so much as having disease because it's PN0. Now, the radiotherapy part will be a little different. If you see isolated tumor cells, we may not want to abide by the study. They ask us that question. We haven't looked at it yet in the B51 because we collected the data. We said, in a form where your node's negative. We didn't ask were they I+. We can go back and review the pathology reports. But the other thing about that is that isolated tumor cells are not very common. I mean, in the study that I showed you from San Antonio, 1.5% of the patients had isolated tumor cells. So it's not a big issue. But the answer is we're not going to ask you to do more. You're already doing your job. Very well, I must say. Make us look good. Other question? Yes.
Hi, thank you for being here. I'm Dr. Pontos, one of the surgeons. I have two questions. I'm sure the first one is, we have discussed about the first one many times. And the first one is, do you feel that removing less nodes from the axilla eventually, is getting us to a point where we'll have less information which will influence our decision on adjuvant treatment, especially for patients with initially larger, bulkier nodes. This is the first one. And the second question is, do you feel that this strange difference in the recurrence or the usefulness of radiotherapy to the nodal areas is because of the tendency of the tumors to recur in different time points after initial treatment? So aggressive tumors tend to recur earlier,
Right.
etc., etc.
Yeah. So the first question, I think, is a good question. Do we need to take more nodes, or are we okay to take less? And I think, as far as the sentinel node biopsy alone goes, the answer would have been yes. More nodes gets you better false negative rate, much lower. When you introduce the targeted dissection, though, I think the numbers are so low, and the false negative rate is almost down to 1 or 2%, 3% maybe. So I don't think taking more nodes, obviously, doing what we call the targeted axillary dissection, which is removing the clip node plus the sentinel node. So by definition, we usually remove 2, 3, 4 lymph nodes from the axilla. And I think that gets us all the information we need, a very low rate of false negative. It's not zero, though. I mean, maybe a patient that you leave behind a node. So your second question, let me make sure the difference. So most of the triple negative patients, or even the hormone receptor negative HER2 positive patients, most of the recurrences occur in the first 5, 6 years, right? Past that, almost recurrences are unheard of to some extent. On the other hand, ER positive HER2 negative patients and even triple positive patients tend to recur later as well. So I think I feel pretty confident here. Our median follow-up was 5 years. The shorter follow-up was 3 years. In other words, we closed the study in 2020, we reported in 2023. So there's no patient with less than 3 years follow-up. So I think we have captured already most of the ER negative recurrences, the triple negative or ER negative HER2 positive. I feel much more comfortable about the data for those two subtypes. And obviously we'll continue to follow. For the ER positive HER2 negatives, recurrences can occur later, although most of the local recurrences typically would occur within 6 or 7 years. So we've captured some of those, but I think we have to be a little bit more cautious about those and continue to follow until we see that the rates stabilize. More events will get us there. Now, obviously, what will happen now, progressively, more and more events will be unrelated to breast cancer. As you get to more follow-up, it will be deaths from other causes, it will be second primary malignancies, contralateral breast cancer, which you hope they will be equally balanced between the two groups. So it's possible that the results even may get better in the subtypes, but we have to wait.
We finished.
All right. Thank you very much. Thank you.